Okay. All right. So what we're going to do today is we are going to dig a little deeper into 12 lead ECG interpretation. And as I had mentioned last week, there is kind of this sea change in the paradigm that we're using to conceptualize people that are having a possible acute coronary syndrome. And that is this concept of what's known as an OMI, an occlusion myocardial infarction. And so what we're going to do today is we're going to spend some time talking about OMI and what that looks like. And so I actually created, this will be the first time that anyone's ever seen this. This is a presentation that I've created that is going to talk about this in some more detail. So let me go ahead and share this with you all, and we'll see how it works out. Maybe it'll be disaster, but I suspect it'll work out okay. One never knows these things. Just allow everything to catch up here. All right, there we go. Okay, so what we're talking about today is the cult of OMI and changing the myocardial paradigm one soul at a time. So kind of a bit ironic, a little bit of irony, but be that as it may, let's go ahead and dive right in here. Okay, so the cult of OMI. So we'll just kind of get some of the customary stuff out of the way. I don't have any financial, ethical, or moral conflicts to declare. I am using several online resources for many of the ECGs, and there are some direct quotes I've taken. And the use of this material is purely for educational purposes, and I'm referencing this material at the end of the presentation. All right. So what are the learning objectives for the next hour or so? Well, there are really four major learning objectives I want to cover today, and that is one, define occlusion myocardial infarction, or OMI. What is it? And how do we define it? And two, how do we differentiate OMI from STEMI, which is something that we've all learned about already? And then we want to identify the need to use the OMI paradigm. And then fourth and final, last but certainly not least, I want to be able to identify 7 common ECG manifestations of OMI. And I've just coined the term the Magnificent Seven. So these are the 7, and this is not by any means all inclusive, but these are 7 common and perhaps easier to identify manifestations of OMI. Okay. So let's just again review what a normal 12-lead ECG should look like. So you should have, when you look at a 12-lead ECG and you're analyzing it, you should have positive deflection in leads 2, 1, 2, and 3. So your limb leads should all be upright. That's what we mean by the positive deflection. And then that suggests that you're dealing with normal axis. So 1, 2, 3 should be upright. V1, on the other hand, should deflect downwards. So you have negative deflection V1. You should have normal R wave progression starting at V1 where you're negative, and then V2 you'll become positive, V3 more positive, V4, and then V5 the most positive, and then V6 will be positive, but it won't be as tall as V5, right? And so you have this R wave progression where the R wave starts small, gets larger, and then drops down, something kind of like that. As you progress through the precordial leads, that's good. And you have no elevation or depression at the J point to include T wave inversion. And you can see that the ST segments are all normal at the J point. AVR, of course, in most cases, we are not looking at it to identify any specific area of the heart. V1, everything should be inverted. So that's normal to see everything negatively deflected, inverted in V1. And then you look at the J point is normal throughout the precordial leads as well as one in AVL. Okay, so that's more or less what we're looking at with a normal ECG. If we look at the QRS axis, it's 54 degrees, and that lies within that 0 to 90 degree axis we consider normal. Right, so 0 degrees lies along lead 1 there, and then 90 degrees in that axis. If it falls within that 0 to 90 degrees, we say that that axis is normal. So everything's looking good. This is a normal ECG. This is what we want to see. All right, so classically, we conceptualize an acute coronary syndrome. We've talked about what acute coronary syndromes are as falling into one of two paradigms, right? So either somebody is suffering from a STEMI, and that's the ST elevation myocardial infarction, or they fall into the what's known as an NSTEMI, non-ST elevation myocardial infarction / unstable angina. And so what you get is you get somebody that has signs and symptoms of an acute coronary syndrome. You perform a 12-lead ECG, and then based on the ECG findings, we categorize them as STEMI or NSTEMI / USA. And for them to fall within the STEMI category, they need to have a greater 2 millimeters or more ST elevation in a single lead, or 1 or more millimeters of ST elevation in 2 or more contiguous leads. Those are the classical criteria. If those criteria are met, then we say that this individual has a STEMI and that they need to immediately go to a cath lab, right? Immediate cath lab activation, code heart activation. If, however, they don't have ST elevation that meets criteria, or they have ST depression without elevation, we would classically put them into the NSTEMI category, right? And in this case, they would not immediately go to the cath lab. In fact, there would be delayed cath lab activation, and we would do extended medical management, right? We'd continue giving them nitro, we would load them up with anticoagulants and P2Y12 inhibitors, and maybe take them to the cath lab in a day or two, or maybe do stress testing and things of that nature, but they wouldn't immediately go to the cath lab. All right. And that's kind of where we've been for really since about 2000 or so, when the term STEMI became integrated into our not only vernacular language, but professional language. Okay. But what is this concept of OMI? Well, if you remember from last week, I said up to about a third, somewhere around 30% of patients who fall into the NSTEMI unstable angina USA category end up having a total or near total occlusion when they finally go to the cath lab. All right. So around a third of those patients that don't meet that STEMI, the classical STEMI criteria, that fall into the NSTEMI criteria, end up having a total occlusion of a coronary artery. Some studies suggest there are poor outcomes in NSTEMI patients. We talked about some of those studies, Jesse, TEMI3, and others. And these poor outcomes are probably due to the delay in care, that these patients are not going to the cath lab like they are the STEMI patients. And so what we've been able to identify over the last several years is that there are several findings beyond STEMI that suggest total or near total occlusion of a coronary artery without adequate collateral injury and infarction that involves the entire thickness of the myocardium, and that is sometimes referred to, if you are only involving a part of the myocardium, some people call this a subendocardial injury. These are sometimes referred to as non-Q wave injuries. And remember, Q waves, pathological Q waves are what you get when you actually have death of heart muscle. And then you have what's known as a transmural injury, where you get the entire thickness of the myocardium that is substantially injured. And this is where you can get your Q waves. So you may hear somebody coin the term a non-Q wave MI or a Q wave MI, and that's just referring to the amount of injury. So what we're worried about here with an OMI is that you have a total or near total occlusion of a coronary artery that is causing transmural injury, ischemia, infarction, right? That's what we call an OMI, an occlusion myocardial infarction. All right. And this was first coined by Smith et al. In their publication, the OMI Manifesto, back in 2017. And since then, a lot of additional work has been done. All right. So that's what OMI is. So when we think about OMI, I want you to think of 7 findings that suggest OMI. All right. So instead of STEMI and NSTEMI, you've got acute coronary syndromes, a suspected acute coronary syndrome. You do a 12 lead. And if you see any of these 7 findings here, these 7 findings all collectively fall under the umbrella of OMI, or occlusion myocardial infarction. So if somebody is having that classical STEMI, right, ST elevation that meets STEMI criteria, that is a type of OMI, as well as hyperacute T waves, de Winter T waves, posterior MI, South African flag sign, subtle ST elevation in inferior leads with subtle reciprocal ST depression in lateral leads, and positive Smith modified criteria, specifically Sgarbossa criteria in left bundle branch block and ventricular pace rhythms. So these 7 findings are common manifestations of OMI, right? So we're expanding what needs to go to the cath lab emergently, right? So STEMI is no less important than it always was. It's just there are other things that are as important as STEMI. All right. And in fact, in October of 2022, the American College of Cardiology published guidelines that state not OMI, but they use the term STEMI equivalent. And they say that there are several findings that are equivalent to STEMI. So they don't use the term OMI, but they essentially are saying the same thing. And they include hyperacute T waves, posterior MI, de Winter T waves, and Smith modified Sgarbossa criteria, as well as the classical STEMI criteria. We are adding a couple more things on top of that because they are subtle but very important, and that is the South African flag sign and the subtle ST elevation with reciprocal changes. So what we're going to do is we're going to kind of take a look at these and apply a new paradigm. So we have somebody that has signs and symptoms of an acute coronary syndrome. We do a 12 lead, and based on the 12 lead findings, we'll categorize them as falling into OMI, occlusion myocardial infarction, or NOMI, non-occlusion myocardial infarction. So what we're trying to do is, it used to be STEMI, right, and NSTEMI, but we know that somewhere around a third of those NSTEMI patients have a total occlusion. And so what we're doing is we're trying to employ new techniques to identify those third or so of those NSTEMI patients and get them to the cath lab as fast as the STEMI patients, right? And so this is where the OMI moniker comes into play, right? So when you have OMI, you've got STEMI, hyperacute T waves, de Winter T waves, posterior MI, South African flag sign, subtle ST elevation with reciprocal depression, and positive Smith modified Sgarbossa criteria. All of these things need to immediately go to the cath lab. And if they don't fall into this OMI, rather they fall into the NOMI, then you can go with urgent or delayed cath lab and go with medical management, additional workup, do serial 12-lead ECGs, serial cardiac enzyme measurements. All right, so let's just review classical STEMI criteria. I know we just reviewed a homework assignment where this came up, but remember it's 1 millimeter or more ST elevation in 2 or more contiguous leads. And remember 2-3 AVF are contiguous, V1 through V4 are contiguous, and then V5, V6, 1, and AVL are contiguous. Those are the 3 major contiguous lead groups. All right. 2-3 AVF is the inferior wall of the left ventricle, primarily involves the right coronary artery. And other structures impacted include the right atrium, the right ventricle, and the SA node. V1 through V4 are the anteroseptal walls of the left ventricle, and that primarily includes the left anterior descending artery. And then V5, V6, 1, and AVL, of course, are the lateral, or look at the lateral wall of the left ventricle, and this tends to be the circumflex artery. And then if you have 2 or more millimeters of ST elevation in a single lead, that is the other major criteria. So over here on the left, you can see this tombstone elevation that you get in the anteroseptal leads, as well as a little bit in the lateral leads. That all meets classical STEMI criteria. So that's a STEMI, which is a type of OMI, and it needs to go to the cath lab. And then over here on the right, you've got the fireman's hat elevation in 2-3 and AVF with reciprocal depression in 1 and AVL, and that is that classic inferior STEMI. Again, it's a type of OMI, and it needs to go to the cath lab. Okay, so at this point, we're all pretty good, I think, on identifying STEMI, but let's talk about some of these other findings that fall under the umbrella of OMI. The first thing I'm going to talk about are hyperacute T waves. And I've mentioned hyperacute T waves in other lectures, but let's just talk about what they actually are and what they actually look like. So these are T waves that are large and out of proportion when compared to the QRS. So if you look at the QRS complex, if you have a little QRS complex, you should have a fairly small T wave. And if you have a T wave that is disproportionately large compared to the QRS complex, we would call that a hyperacute T wave. And these tend to be greater than 5 millimeters in limb leads, right? So 2, 1, 2, and 3, right? The QRS, right? How tall the T wave is. If the T wave is greater than 5 millimeters tall, that would be considered hyperacute. And if it's greater than 10 millimeters in the precordial leads, so V1 through V6, right, you're looking at greater than 10 millimeters. All right. Now, these hyperacute T waves tend to be wide and broad. They're not as peaked or pointy in general. And that's important for differentiating hyperacute T waves from other findings. So they tend to be broad, so they're wider and they're taller, kind of like that. They tend not to be as peaked or pointy. And when you see a peaked T wave like this is called a tented T wave, and that tends to be indicative of hyperkalemia. So hyperkalemia can cause a large T wave, but the morphology of hyperkalemia tends to be a little different than a hyperacute T wave. So let's look at some examples. So here are some examples of hyperacute T waves, and these are associated with ST elevation. So you can see the J point right here in V2, and then the J point right here in V3. So you've got this ST elevation going on, but you also have this large, wide, tall T wave that is out of proportion when compared to the QRS complex. So they're broad, that means they're wide, and they're tall. They tend to be symmetrical, so it looks more or less the same on both sides. All right, and they are large in comparison to the QRS. This suggests OMI. Now, again, you have STEMI in this V2 and V3, so you don't even need to really go beyond that. But if you didn't have that ST elevation, just the presence of these disproportionately large T waves is enough to say that this is an OMI and this is someone who needs to go to the cath lab. So let's just compare that to some other things that can cause large T waves. And the two major things are hyperkalemia. And remember, hyperkalemia causes a peaked T wave. So the peak T waves tend to be narrow and tented, all right? So you can see that the T wave is narrower and it tents, right? So it kind of gets narrower as you go up to the top. Whereas a hyperacute T wave tends to be wider, broader, all right? And not as pointy or spiky at the top, all right? And then the other major thing that can cause large T waves is something called benign early repolarization. We'll talk about that in more detail in other lectures. And benign early repolarization is a common finding in typically younger, healthier people. But there are some things that are very common in benign early repolarization, and that is this right here. You see this little notch here. So you get a notch at the J point. And so when you see large T waves with some ST elevation in a younger, healthier person, typically under the age of 50, and you see that little notch occur after the QRS complex at that J point, that suggests benign early repolarization, all right? So hyperkalemia and benign early repolarization are two findings that can cause large T waves. So history and a close examination of the T wave morphology is in order to differentiate the differentials, right? Are we dealing with benign early repol? Are we dealing with hyperkalemia? Or does this seem to be a legitimate hyperacute T wave? All right, so here's the case study. So I have a 45-year-old male with sudden onset chest pain that resolves after nitroglycerin and aspirin. So here's our 12 lead. We give some nitro, give some aspirin, we get a 12 lead here. And if you look at this 12 lead, there's not a whole lot going on, right? So we look at 2, 3, AVF. There's not a whole lot going on in inferior wall. You've got some low voltage QRS complexes. You do have lead 3 is deflected downward, so you've got up, up, down. So the axis, you have some axis deviation going on, but nothing super overt at this point. We look at V1, V2, V3, and V4, the anteroseptal wall. And you should, if you're really looking closely, you might notice that you've got a T wave that is pretty long here. It's pretty wide. It's not super tall, but it is kind of large. So maybe there's a little something going on there, right? Maybe. If we look at V5, V6, 1, and AVL, again, a whole lot of nothing going on. So this is a very non-specific ECG, right? Maybe there's a little hint of something going on. It's hard to say. Certainly, signs and symptoms are concerning. So let's move on. So 5 minutes later, right, so we're transporting, his pain returns. And this is important for us to do as paramedics. you should be doing serial 12-lead ECGs. So if you have somebody that has concerning signs and symptoms, you should be doing a 12-lead ECG every 5 to 10 minutes or so, because these changes can occur very quickly. So his pain comes back a few minutes later. We get another 12-lead ECG. And if you look at this, there is no elevation here, right? We look at this 12-lead ECG and there's no elevation. There is no ST elevation. You've got some depression in V2. You've got some depression in V3, a little bit of depression in V4 there, right? No ST elevation. Now, because we have depression in V1, 2, or 3, you need to be thinking posterior MI, right? And you want to do V7, V8, and V9. And let's assume that we do that and there is no elevation. So there's actually not a posterior STEMI going on here. So in this case, right, the ST changes do not meet STEMI criteria, right? This is something that would fall into the NSTEMI category using the old paradigm, right? We would not call the cath lab. This patient would not immediately go to the cath lab. So what do? Well, you give additional doses of nitro as well as fentanyl, and then the patient's delivered to the ER. The physician suspects NSTEMI and orders cardiac enzymes, and so that patient's going to sit in the ER for a while. But what do you all notice about these T waves here? Is there anything concerning about these T waves that you're seeing?
They're hyperacute.
They're hyperacute, yeah. So this is actually an OMI. And so hopefully you're beginning to see how using the OMI paradigm is a lot more helpful and can actually capture these patients. So 90 minutes later, so this guy's been sitting in the emergency room, and these are actually ECGs from the same patient too. So an hour and a half into what's going on with this patient, he starts developing bilateral crackles and hemodynamic instability. Cardiac enzymes come back, his troponin is markedly elevated. So at this point, now we see ST elevation in V2 and ST elevation in V3 and a little bit of ST elevation in V4. And that elevation is a millimeter or more. It's a little more in V2 and it's about a millimeter in V3 and V4. So now finally, right, 95 minutes or so into the care of this patient, finally, now he meets STEMI criteria. And now, after over an hour and a half of sitting, having a heart attack, infarcting, and if you look at this, what do we see here? Well, we see that elevation in the anterolateral leads. And so, right, that's a big part of the mass of the left ventricle that's impacted. So now the patient's sent to the cath lab. They found 100% occluded left anterior descending artery on this patient with TEMI zero flow, right? And so there's no collateral circulation, there's no blood flow. So they do PCI. Unfortunately, the patient remains unstable in cardiogenic shock. They had to put in an Impella and use inotropic agents to support his hemodynamics. He does eventually get to go home, and he's discharged with a 30% left ventricular ejection fraction. We'll talk about that during cardiology. But in a mid 40-year-old patient, your left ventricular ejection fraction should be, around 60 or 70%. So basically what happens, this patient lost a big part of his left ventricle, and he now has congestive heart failure with reduced ejection fraction, which means the rest of his life will be severely impacted negatively. And we might have been able to avoid this severe morbidity that has occurred had he gone to the cath lab sooner and had they opened up that LAD sooner. So hopefully this is helping you to understand why it is so important to look beyond just STEMI. Okay, and this is just another comparison of hyperacute T waves versus hyperkalemia. You can see that there are some distinct similarities, right? But the big thing here is with hyperkalemia, those T waves, right? You kind of get a little more tenting, and you can see that there's like a little detent here as that T wave goes up, right? So you've got that like little detent there. Whereas here, it's pretty symmetrical over here on the left. We're looking at these hyperacute T waves. So hyperacute T waves and hyperkalemia can look very similar. And this is where history really plays a role, right? If this is a patient that has a history that suggests hyperkalemia, you might want to take actions to treat that, right? And what would we, if we are thinking hyperkalemia, what's a primary treatment? What are our initial action drills, so to speak, to address life-threatening hyperkalemia?
Calcium and bicarb.
Yeah, so calcium to buy us some time, sodium bicarbonate to drive potassium ions back into the cell, high dose albuterol, right? Insulin and dextrose if we have the ability to do that, and then dialysis. Yeah, excellent. But in this case, you've got this patient in his mid-40s, no history of hyperkalemia, no history of a renal crush injury, of rhabdomyolysis or anything like that. And so we're much more concerned about this being an OMI. And so this over here, this is somebody who needs to go to the cath lab. All right, moving on. Let's talk about De Winter T waves. So De Winter T waves, think of these as a variation of hyperacute T waves, because that's kind of what they are. So De Winter T waves are tall, prominent symmetrical T waves in the precordial leads. So we don't see De Winter T waves in the limb leads. All right, these are in the precordial leads, so V1 through V6. All right. And what you get is you get upsloping ST depression. So remember I said there are three major types of ST depression. You've got the downsloping ST depression. See if I can draw that. Right, so that's downsloping ST depression. And then you've kind of got that horizontal ST depression. And then you've got upsloping ST depression. It looks something like this. All right. So you've got the downslope, the horizontal, and then the upslope. And with De Winter T waves, you're going to get that upsloping. So you're going to have large, tall, broad T waves that are peaked, but you're also going to get ST depression. All right. And that ST depression is going to go, it's going to have this little upslope to it right there that you see. All right. And you often will get reciprocal elevation of less than a millimeter in AVR. So again, this is where AVR becomes an important tool, right? So you see these abnormal T waves in the precordial leads, and you see this depression. Look at AVR, and if you have subtle elevation, right, half a millimeter to a millimeter, subtle elevation of the ST segment, that is more evidence that you're dealing with an OMI. All right, and then typical STEMI morphology may precede or follow the De Winter pattern. So what you can get is you can have somebody that will have more classic ST elevation, and then they can go into this. right? And so when you do a 12 lead, you don't necessarily see the elevation, but you see these De Winter T waves, or they start off with De Winter T waves. And as they progress through their heart attack, they develop ST elevation. And this can dynamically change back and forth. All right. So again, think of these as a kind of hyperacute T wave, because that's kind of what they are. And they kind of point to the same thing, that this is an anterolateral OMI. So here is an example of De Winter T waves. We got a little bit of interference on this 12 lead, but you can clearly see in V2, V3, V4, V5, and V6, right? You've got this ST depression. The J point is below the baseline. You've got this upsloping to the T wave. And if we look at AVR here, you can see that I've got a little bit of subtle ST elevation in AVR, right? Now, if we were to run this through classic STEMI criteria, the only ST elevation we have on this 12 lead is an AVR, and we don't use AVR because the AVR doesn't look at any specific wall of the heart. So if you were to give this 12 lead to somebody who didn't know anything about OMI, they would look at this and go, oh, this is an NSTEMI. This is someone who does not immediately need to go to the cath lab, when we should know better now. We know, hey, you know what? This is one of those 30% of the cases that are actually having a transmural injury. And so they need to go to the cath lab immediately. They're having an OMI. All right. Next is posterior MI, and you all are actually fairly well versed on this because we talked about this last week. But just as a review, the posterior wall is not directly visualized on the 12 lead, right? At least on a standard 12 lead. And just as a reminder, remember the anteroseptal wall is reciprocal to the posterior wall, specifically leads V1 through V3. And ST depression in V1 through V3 is highly suggestive of posterior wall. All right. And the rule of thumb that I'm teaching you all is, if you see depression in V1 through V4, doesn't matter what else is going on, that should automatically mandate posterior leads, even if they're negative. It is an incredibly low risk, high yield test. There's almost no risk for getting posterior leads on somebody, right? And just as a reminder, remember the depression tends to be horizontal. So with De Winter T waves, you get that upsloping depression, but remember with posterior STEMI, you tend to have that horizontal flattening out. And then when you mirror sign it and flip it around, it looks like elevation, right? So the morphology of the depression can point you in certain directions as well. All right, so here is an example of that horizontal depression that you see. We're looking at V2 specifically. And so then what I've done here is we've taken V2 and we've flipped the ECG, and then we're looking at it in a mirror, and this depression actually looks like elevation, right? When you do that, when you flip it. And again, that's called the mirror criteria, right? And again, you see this, and that should prompt you to immediately get posterior leads. And I have an example of that. So remember, V7, V8, and V9 are our posterior leads. So here's the 12 lead. So we look at this 12 lead. It's pretty obvious we actually have a STEMI going on. So you've got elevation in 2, 3, and AVF. And it looks like it meets STEMI criteria. So we have a STEMI. And then when we move on to V1, V2, V3, and a little bit in V4, you can clearly see that depression there, right? And so that suggests posterior. And here, AVR is not elevated, right? AVR is not elevated. So we're not thinking de Winter T waves, even or hyperacute T waves, even though that depression does not have a hyperacute morphology to it. And then you can see we've got a little bit of elevation here in V5, V6, and 1, and just a slight amount in AVL. So that looks like the lateral wall, the infralateral walls are taking a hit. So we'll go ahead and run our posterior leads. And that's exactly what we did here. And so V4 becomes V7, V5 becomes V8, V6 becomes V9, and you can clearly see the ST elevation in those posterior leads. And so I positively identify the presence of a posterior STEMI or posterior MI in addition to the infralateral stuff that we're seeing. All right, moving right along. There is another finding we need to be aware of, and this is known as the South African flag sign. And so what I want you to do is I want you to think of the South African flag, and the South African flag has this green Y on its side. And if you imagine putting the South African flag on top of a standard 12-lead ECG, so remember your standard 12-lead ECG, you start with your limb leads, leads 1, 2, 3, right? 1, 2, 3. You guys see that there? And then a VR, AVL, and AVF, and then V1 and V2 and V3. All right. And if you look, everything within the green, within that Y on its side, is what is included in the South African flag sign. All right. So in the South African flag sign, what you get is you can get either subtle, and when I say subtle, I'm talking about less than a millimeter of ST segment elevation or depression, right? That's what subtle means, right? So what you get is you get subtle or pronounced ST elevation in 1, stop, in 1, all right, AVL, and V2. So you get subtle elevation in 1, AVL, and V2, or it could be pronounced elevation, and then you get depression in lead 3. All right, so South African flag is just kind of a handy way to memorize the changes that we see within the South African flag sign. And so when you see these changes, these indicate that there is a blockage in the first diagonal branch of the LAD. So remember, the LAD has diagonals, D1, D2, etc., and then septal branches, S1, S2, S3, and so on. And so this is an occlusion of the first diagonal artery that comes off of the LAD, which feeds the high part of the lateral wall. All right. And so what we're looking at here is if you have this elevation in 1 AVL and V2, and these are not contiguous, right? V2 is not contiguous with AVL. So this is something that can fall outside of the STEMI paradigm if the elevation is subtle. Okay. But this suggests that you are infarcting the high portion, the superior portion of the lateral wall. And this is called a high lateral myocardial infarction. All right. So here I've superimposed that, the South African flag, on an actual ECG. And so you see, you've got this little bit of elevation here in one. You've got pretty decent elevation AVL. You've got a little bit of elevation here in V2. I've drawn the J point. And then you've got this depression in 3. And so we take the South African flag away. All right. And we just look at it. You can see elevation in 1, elevation in AVL, and elevation, very subtle, but a little bit in V2. And then you have this depression in 3, right? And this is the South African flag. It's that inverted green Y, okay? Okay, moving on. The next finding is subtle ST elevation with reciprocal depression. So you can have ST elevation that does not exceed 1 millimeter, but if it is associated with reciprocal depression is a powerful indicator of myocardial infarction. So even though you may have ST elevation that is under 1 millimeter, so again, this is not something that meets STEMI criteria, because you have the presence of reciprocal depression, that again suggests that there is an active infarction going on, an OMI. All right. So if we look at this ECG here, all right, if you look at leads 2, 3, and AVF, you can see you have a little bit of depression just under 1 millimeter, right? Very, very subtle depression. You might even be pushing 1 millimeter in AVF, but it's under 1 millimeter in 2 and 3. So yes, there's depression here, but you could not convince somebody that this is a STEMI because it's not a STEMI, right? But what should be very powerful here is AVL. You've got that depression. And we remember that AVL, and we have a little bit of depression in 1 here as well, right? But it's definitely pronounced in AVL. And remember, 1 in AVL is what? It is reciprocal with the inferior wall. So it is very rare for you to have ST elevation that is associated with the reciprocal depression that is caused by anything other than a myocardial infarction, right? That's what makes this so powerful. So reciprocal depression is a very powerful indicator of a myocardial infarction when you have elevation in that reciprocal wall. And the infralateral tends to be where this shows up, right? So depression in AVL is a powerful indicator of inferior MI, as it is the most reciprocal lead. So even though STEMI criteria is not met, this is an MI, needs to emergently go to the cath lab. This is an OMI here. All right, moving on. So what about left bundle branch block and ventricular paced rhythms? So what if you have someone that has signs and symptoms of an acute coronary syndrome, but they have a left bundle branch block, or they are in a ventricular paced rhythm? Well, left bundle branch blocks and ventricular paced rhythms tend to cause ST aberrations or abnormalities. ST elevation is very common with left bundle branch block and is very common in ventricular paced rhythms. So with signs and symptoms of acute coronary syndrome, we often state, or we used to say, that if somebody has a new onset left bundle branch block, or presumably new, that they should go to the cath lab, right? Because we used to think, well, there's not anything I can do, so I'm just going to assume that they're having an MI and they need to go to the cath lab. But here's the problem, right? We can't just send every person that has chest pain and ECG anomalies to the cath lab, right? We can't do that. We need to differentiate, okay, who needs to go and who doesn't need to go right away. And what about the pre-hospital implications, right? Where we're not in a hospital, we don't necessarily have access to somebody's medical records where we can compare the ECG that we just obtained to an old ECG, right? So we even have more limitations. And so the question is, are there any tools that can help push us in one direction or another? Well, there are, otherwise I wouldn't be talking about them. And these tools really come down to something called discordance. So one of the keys to understanding what is known as Sgarbossa criteria is something referred to as discordance. So because ventricular depolarization is abnormal in ventricular paced rhythms and left bundle branch blocks, repolarization should also be abnormal. Okay, so what you should see in a left bundle branch block and a ventricular paced rhythm is the T wave moving in the opposite direction from the QRS complex. That is what discordance is. So if the QRS goes up, the ST segment should go down. This is called discordance. And a certain amount of this should be seen in left bundle branch blocks and ventricular paced rhythms. So here I have a diagram with looks like a bundle branch block. You've got a wide QRS complex. So here you've got the QRS complex deflecting positively. So you would expect the T wave to deflect negatively. That is appropriate discordance. Likewise, if the QRS complex is negatively deflected, the ST segment will be positively deflected, which means the J point is up here and you have ST elevation, right? ST elevation is a common consequence of a left bundle branch block and a paced rhythm, but some amount of this is going to be normal and appropriate, and it will be caused by the bundle branch block or the paced rhythm. This is known as appropriate discordance. All right. And this is based on this idea of appropriate discordance, a set of rules have been developed that can be used to analyze the ECG for evidence of OMI. And the current rules that are being used, the most contemporary set of rules are known as the Smith modified Sgarbossa criteria. So in the early, I believe it was the late 90s or early 2000s, Dr. Sgarbossa looked at many cases of left bundle branch block and paced rhythms, and she developed kind of the original criteria. And then later on in the late 2000s, Dr. Smith came along and modified the rules a little bit. In fact, the third rule is the one that he really modified, and that's what we're going to talk about today. But because this is a tricky area to talk about, what I would like to do is I would actually like to take a break before we dive into the gory details of Sgarbossa criteria. So let's go ahead and do that right now. It's 10:43. 10:44 now. So before I let you all go for a break, are there any questions over anything so far? Is everybody okay with the concepts we've covered thus far? Okay, I don't see, make sure I don't have anything in chat. Okay, it looks good. All right, so it's 10:45. How about I see you all back at 11 o'clock? Okay, welcome back, everyone. Before we complete the second half of this discussion on OMI, are there any questions over the content we've covered thus far? Okay, I think I'm caught up on chat, it looks like. Okay, well, let's continue on then. So we just kind of built up some basic intuition for thinking about the Sgarbossa criteria, specifically the importance of appropriate discordance. So remember, discordance is where the QRS complex and the T wave are moving in the opposite directions. And this is something that we would expect to find in the setting of a left bundle branch block or ventricular paced rhythm. So from there, let's talk about deviations from that discordance. And there are three primary things that we're going to look for that deviate from this so-called appropriate discordance. All right, and these include the following. If you have concordant ST elevation greater than 1 millimeter in more than one lead. So remember, concordant elevation should not occur in a left bundle branch block or a ventricular paced rhythm, right? The elevation should be discordant. So if you get ST elevation, the ST segment should be moving in the opposite direction of the QRS. But if you have ST elevation that is moving in the same direction of the QRS complex, that falls outside of what you would normally see. All right. Likewise, if you have concordant ST depression, so the depression of the ST segment is moving the same way as the QRS, greater than 1 millimeter in more than one lead involving V1, 2, and 3. So concordant ST elevation of greater than 1 millimeter in more than one lead, or concordant ST depression that exceeds 1 millimeter in more than one lead, specifically in leads V1, V2, and or V3. And then the third major part of the criteria is the presence of excessive discordance. Okay, so some amount of discordance is appropriate, but excessive discordance, so if the discordance is excessively large, okay, then that is a problem. All right, and the criteria specifically says if you have excessively discordant ST elevation in more than one lead, greater than 1 millimeter of ST elevation, and that elevation is defined as elevation that exceeds 25% the depth of the preceding S wave, right? So you've got your QRS complex. All right. So you need to actually measure how long is the S wave. All right. How long is the S wave? And if the ST elevation exceeds 25% of the length of the S wave, that's what this is talking about. That is proportionately excessive ST elevation. All right. So the ST is discordant, but the extent of the ST elevation measures 25% or more the length of the S wave. All right. So these are the three things that we look at, right? If we have one or more of these three things occurring in somebody with signs and symptoms of an acute coronary syndrome and a left bundle branch block or a ventricular paced rhythm, that would suggest that they're having an OMI and that they need to go to the cath lab. So let's take a few examples of this. So an obvious example is going to be the setting of concordant ST elevation. Get that out of the way. So if we look, and they've actually circled AVL here. All right. So you see how I've got some elevation here. And if you look, the QRS complex is wide, is a wide QRS complex. And when we turn signal it in V1, the QRS complex goes down. So we are dealing with a left bundle branch block. All right. And so when we look at AVL here, you can clearly see that I have got an elevated ST segment that is moving up, right? And the QRS complex is moving up. That's concordance, and we should see discordance. Likewise, if we look at lead 1 over here, okay, you can see the QRS is moving down and the ST elevation is moving up. So that's a little more appropriate, right? That's discordance. So that ST elevation there in lead 1 is not really concerning. That is what we would expect to see. If we look at V2, V3, V4, okay, you see that you've got a QRS that's moving downward. You got your J point here, and then you've got a millimeter or two of elevation there. But again, that's okay because the T wave is moving up and the QRS is moving down. So you have appropriate discordance in those leads. All right. In V5, you have got a little depression here, but you got a QRS complex that is moving up. It's actually biphasic, it's moving in both directions. So maybe a little something here. But if we look at V6, you got ST depression that's moving down, but the QRS complex is moving up. That's appropriate, right? But we definitely have inappropriate concordance in AVL. And so that is very concerning in this ECG. We would not expect to see this. And this is elevation that is not likely to be caused by the presence of the left bundle branch block. It is likely to be caused by the presence of a myocardial infarction. All right. Let's take a look at a ventricular paced rhythm here. All right. So in this case, I've got concordant ST depression. All right. And remember, that's the second component of the Smith modified Sgarbossa criteria. So look at the ST depression here in V2. So you see how the ST depression moves down, and look at the QRS complex. See how it deflects down. All right. So it's moving in the same direction as the QRS. So that's concerning. If we look at V3, you see something very similar. So the J point is here. That's below the baseline, right? So you have ST depression, but the QRS complex is primarily downward and the ST depression is primarily downward. So in V3, you also have this concordant ST depression, right? If we look at V4, get back. Same thing. QRS complex is primarily going down and the ST depression is primarily going down, right? So I have substantial concordant ST depression throughout the precordial leads. V5, same thing. QRS complex is mainly downward. ST depression is downward, right? So V2, 3, 4, and 5, you have inappropriate concordant ST depression, right? So we had an example of inappropriate concordant ST elevation. Here's an example of inappropriate concordant ST depression. You should have discordance, not concordance. All right, and then the final one is excessive discordance, and this is perhaps one of the most important ones, and it's one of the more difficult ones to appreciate. All right, so if I look at this ECG here, so you can clearly see that the QRS complexes are widened, right? And when we turn signal V1, it points downward, so we're dealing with a left bundle branch block. So now the question is, okay, well, is there anything inappropriate here? So we look it over, and just kind of looking it over, you can really see, oh, you know, the QRSs here are going up, The ST depression's down, up, down. That looks good. Here in the precordial leads, the QRS complexes are down, but the T waves are up. And so just kind of consulting it, it's okay. It's like, well, I've got discordance, but this is where excessive discordance comes into play. So what we've done is we've zoomed in on V2 here. All right. We've zoomed in on V2. And what we're going to do is we're going to take a look. So you can see where the J point is here, right? Where the line kind of, the slope of the line changes ever so slightly. So what they've done is they put a line on the J point, and the red line is on the J point. The blue line is the baseline. So what you have here is you have ST elevation, right? And the question is that ST elevation a normal? Is this just normal or normal discordance of the left bundle branch block, or is this abnormal? Is this abnormally large? Well, what we do is we'll take the ST segment, we'll measure, right, and each box is a millimeter. So how tall is that in millimeters? And then what we'll do is we will take the S wave, and that's what they've done between these blue markers here, is they are measuring the length of the S wave, right? So what we're going to do is we're going to take the length of the S wave and we're going to compare it to the length or the amount of discordant ST elevation we have present. And that's exactly what they've done. So the J point is at the red line in V2, right? So you can see right here where the slope of that line changes, that's the J point. All right. And so between the red and blue is the ST segment. That's how elevated it is. All right. And if you count this in boxes, you've got 10 little boxes here. So that gives you 10 millimeters of discordant ST elevation. And the question is that too much or is it okay? Well, let's measure the length of the preceding S wave. That's between these two blue lines, right? So here to here, we'll measure that in millimeters, and that is 37 millimeters. So then what we're going to do is we're going to take the ST segment and we're going to divide it by the QRS, right? So the ST segment is 10 millimeters, right? So I'm going to take 10 millimeters. That's how long it is, the J point elevation. And then I'm going to divide it by the length of the the S wave, excuse me. All right. And that's 37 millimeters. And when I do that, that gives me 27 or 0.27 rather, right? So 10 divided by 37 is 0.27. So the ST segment is 27% the height or the length of the S wave. And remember, 25% is the threshold. And if that exceeds 25% of the total length of the S wave, then this meets that criteria, that this is excessively discordant. Even though it's discordant, it is excessive, and this is in fact suggesting that there is a myocardial infarction going on. All right. So let's take a look here. So what about this pre-hospital ECG in an elderly patient with atypical symptoms? Maybe they have some jaw pain, maybe it's some pain radiating down their arm. So the computer interprets this as a normal sinus rhythm with a left bundle branch block and left axis deviation. Okay, we would expect the left axis deviation with a bundle branch block. So if you just kind of look at this, it's kind of like, well, I don't know. So let's just kind of run through Sgarbossa criteria. Do we have anywhere on this ECG where you have problems? What do you all think? I'll give you a hint. Look at the precordial leads. And do you see something interesting going on in the precordial leads?
Does it have excessive discordance?
Absolutely, yeah. So let's just take a look at V2 here. So here's the R wave, or this is a Q wave, excuse me, because it goes down. And then this is the S wave here, right? So here's your S wave. I'll draw the S wave in red. And then let's figure out the ST segment. So the J point is up here, right? And so if you draw a line through the baseline, this right here is your ST segment. Well, that's looks, just eyeballing it, looks, the ST segment, the length of the elevation looks to be about half of the length of the total length of the S wave, right? So I don't even need to do math to just kind of look at it and go, oh, that elevation is way, way too discordant. Same thing here if we move down to V3, right? So here is the S wave right here. The J point is right here. And so the ST elevation, again, it's about half of the length of that S wave, right? So you have this excessive discordant elevation going on here that goes beyond what you would normally see. So you're actually able to tease out, buried within the information of this 12 lead, you're actually able to tease out the MI or the OMI in this case. So the computer did not pick this up, but it's very clear that you have excessive discordant ST elevation going on here that meets or exceeds the Smith modified Sgarbossa criteria thresholds. So what about NOMI? We really haven't talked about NOMI, have we? So what about all those other patients that legitimately are not having an OMI? What do their 12 leads look like? Well, let's do just a quick little case study here. This is a middle-aged male with symptoms of acute coronary syndrome. He has depression in multiple leads, but not reciprocal. So that's a big thing. Seeing ST depression seeing ST depression without reciprocal elevation in other leads. All right. Or subtle elevation in precordial leads that does not meet STEMI criteria. So if we look at this ECG here, okay, we look at this ECG here, let's start with 2-3 AVF, the inferior leads. So I do have a little bit of depression here. So I'm going to look at one in AVL, because if there's elevation in one in AVL, then that would seal the deal, even if this was subtle. But if you look at this one in AVL, there really isn't anything going on there, right? There really isn't any kind of elevation that meets any thresholds. So this depression that we're seeing is not a reciprocal change, right? If we look at the precordial leads, I have ever so slightly, maybe ever so slightly, like less than half a millimeter in V1 and V2 of elevation. That doesn't meet any criteria, any threshold. If I look at V6, I've got ever so slight depression here, but it doesn't appear to be reciprocal to anything. So I kind of have this depression. I have a little bit of elevation in AVR that's concerning, okay? And elevation in AVR is often discounted, but this is concerning for advanced coronary artery disease, particularly if you have elevation in AVR and you have depression in multiple other leads, okay? But at the end of the day, is this somebody who's having an acute occlusive myocardial infarction? And at the end of the day, no, right? At the end of the day, this is not something that falls into the MAG 7, the 7 things that we've talked about. Now, this is still a problem, right? This is somebody who has coronary artery disease. This is somebody who may even have some occlusion going on, but they either have a small occlusion or there is enough collateral circulation that they are not having this transmural infarction. And so this is kind of what you would expect to see in somebody with NOMI. All right. Yeah, there's a problem. There's stuff going on, but they don't need to go to the cath lab in the next hour or two. This is someone we can medically manage. We can watch him. We can do serial 12 leads. We can get cardiac enzymes, and we can kind of figure out what we need to do from there, right? So I just kind of want to also include NOMI because I've been talking about OMI, but you know what? There are going to be a lot of patients who legitimately are not going to need to go to the cath lab right away. And this is kind of what you would expect to see in that population. These subtle findings that are not associated with reciprocal changes. And then don't forget the mimics. And we're going to talk about these probably tomorrow. But there are many conditions that can mimic OMI, that can mimic NOMI, and that can mimic STEMI, which is a manifestation of OMI. And we will, again, talk about some of these, many of these tomorrow. And these include things like benign early repolarization, which we mentioned today, pericarditis, myocardial contusion, something called Wellens syndrome, Wolff-Parkinson's-White disorder. Elevated intracranial pressure can be associated with some specific ST segment changes, hypothermia, and the presence of J waves or Osborn waves, Brugada syndrome, which is a sodium channel. It's a genetic disorder where you have a defective sodium channel. Drug and electrolyte effects, sodium channel blockers, for example, that can widen the QRS complex. So things like tricyclic antidepressants, Benadryl, let's see, certain SSRIs like bupropion that can block sodium channels, certain antipsychotics, and other medications. Digoxin has causes some characteristic ST segment changes. Potassium, specifically hyperkalemia, tends to impact the T wave and the ST segment. A left ventricular aneurysm, or an embolism, excuse me, you have a large blood clot that forms in the left ventricle. And if the left ventricle is larger than normal, or it undergoes hypertrophy, the mass is increased. That's something called LVH, or left ventricular hypertrophy. So these are all things that can mimic occlusion myocardial infarctions or non-occlusive myocardial infarctions. And we will talk about these in more detail tomorrow, however. All right. So to kind of conclude things, the standard STEMI paradigm can result in missing large numbers of patients who are experiencing a significant occlusion that results in injury and infarction. These patients are better identified using the OMI paradigm, and 7 common manifestations of OMI include STEMI, hyperacute T waves, De Winter T waves, posterior MI, South African flag sign, subtle ST elevation with reciprocal depression, and a positive modified Smith-Sgarbossa in the setting of a left bundle branch block and ventricular paced rhythms.